iGlaucoma presents Podium Presentations on Glaucoma Rewind for national presentations that were missed or those you watched but wish you could press rewind and watch again. In today's podium presentation, the talk was presented at the annual Envision Summit Meeting 2022 in Puerto Rico in the Glaucoma Program section on Experience with MIGS Procedures.
Hello, my name is Dr. Constance Okeke, and I'll be sharing with you some experiences with the OMNI and the GATT. These are my financial disclosures. The GATT, or gonioscopy-assisted transluminal trabeculotomy, was first termed in 2014 by Dr. Ron Feldman and Associates. It is a technique that works at the mechanism of the trabecular meshwork, removing it in order to create increased outflow through the outflow channels directly to Schlemm's canal. This is a procedure that can be used with a fibroproline or a catheter in order to unroof up to 360 degrees of the trabecular meshwork. The OMNI surgical system does use this technique as well, in addition to using viscodilation. With the OMNI handpiece, one can insert into Schlemm's canal and exude viscoelastic to do a canaloplasty, and this will help to open up the Schlemm's canal, open up the trabecular meshwork, flush it, as well as open and dilate the outflow system, outflow channels. Then the catheter can also be used to unroof the trabecular meshwork like the GATT procedure. The case study will help to describe how to utilize this system well in patients. This is a 66-year-old male who was referred by an optometrist for cataracts and glaucoma. He had a previous SLT that worked for about 8 months. He was not on drops and he was complaining about visually significant glare and difficulty driving at night. He had medications of lisinopril and metformin for his hypertension and diabetes, and he did have a history of non-compliance. His ocular exam revealed good vision, but he did bat significantly to 2150 and 2200 in the right and left eye. His tonometry showed pressures of 22 and 23, and his pachymetry showed normal with a wide open angle and cuspis ratio of 0.7 in both eyes. His visual field showed a significant decrease in retinal nerve fiber layer in both eyes and correlating visual field deficits in superior and inferior quadrants. The assessment was uncontrolled open-angle glaucoma, and the surgical plan was to do a cataract extraction, standard IOL, and also combine this with OMNI. This is the OMNI device. It's inserted into it at the end, viscoelastic, which exudes out the other tip, along with a microcatheter. Here are surgical steps. After a successful cataract surgery is done and an implant is placed in the eye, you will fill the eye with viscoelastic to make sure it's firm. Then you'll enter the tip of the OMNI, followed by a gonioprism, and evaluate the angle to be nice and wide open. With the tip of the OMNI, you will score the trabecular meshwork to create a small goniotomy, and this will allow for you to insert the catheter. Prior to inserting, I will change the angle of the OMNI tip to about 15 to 20 degrees upward, and putting some pressure against the back wall of Schlemm's canal for stabilization. Now I'm entering the catheter, and I'm doing it in a slow, steady fashion in order to evaluate for any tactile cues of resistance or grimacing of the patient, which would alert me to stop and then retract. I'm also using the gonioprism to move around so that I can try to see as much as possible to know that I'm in the right position. I will slowly extend and then come back, and I see that I'm in a good plane. Here the arrow is showing that there's heme in Schlemm's canal, so I know I'm in the right place. Then before coming completely out, I'll reinsert the catheter into the same plane and then be able to do the goniotomy right after that. Here I'm pulling the microcatheter, and you can see the white wall of the back wall of Schlemm's canal, indicating a proper removal of the trabecular meshwork. Now I'm going the other direction, which is nice with the OMNI. You can titrate how much area you want to treat. I'm doing another 180, so a full 360 of the visco canaloplasty, and then about a 90 degrees of the trabeculotomy, so total 180 for this patient. He did very well afterwards with follow-up. His pressures, remember, were 22 and 23. Afterwards, his pressures went down to 16 and 17 at 1 week and stayed in the mid to upper teens for the next several years. His visual fields also showed stability as well as his structure as seen in the OCT below. Additional input for successful procedure. 1. With patient selection, choose wide open angles. Myopic patients tend to be very good with this, with clear delineation of the structures. Also, the stage, mild to moderate, 1 to 3 medications in patients with cataract, or also can be done as standalone. Intraoperatively, make sure that at the end of the case the eye is very firm with hydration. This helps with preventing hyphema postoperatively. And postoperative management, use a low-dose steroid or consider tapering medication and keeping them on their glaucoma medications minus the PGA. And have a very low threshold for adding pilocarpine if excessive heme or inflammation. Thank you so much for your attention, and if you want some additional pearls on surgical success secrets for MIGS, check out my video series, The MIGS Success Surgical Secrets, on my iGlaucoma YouTube channel. Thank you.
Want more videos like this? Check out the iGlaucoma YouTube channel library. Check out the upcoming Season 2 of MIGS Success Surgical Secrets, where a video of common challenges and solutions will be featured. Subscribe to the channel so you won't miss it. Hey, want a must-need glaucoma tool that you can download right now? Grab my 2022 Glaucoma Medication Guide in the description box below. You'll get all the most commonly used glaucoma medications right at your fingertips to help you quickly make decisions about which glaucoma drop is right for your patient. Download it now. Thanks for watching the iGlaucoma YouTube channel, a place for glaucoma innovation made easy for eye care professionals.